I'm interested because in your little film, not little film, but in the film you talked about culture and managing difficult patients. And so what I want to do is talk for a few minutes. You might have to get the hook because I don't have my watch on my wrist. But feel free to think of your questions, and let's save time for questions and answers, please. So, compassion. I could probably have stood here for an hour and talked ad lib about compassion, but when Janice asked me to come and talk with you, I sat down and started looking at my literature, the ethics literature, and then I looked at the philosophical literature and then the nursing literature, and what I realized was that I could study this forever. And you people know more about compassion, certainly, than I. So please, let's make this a conversation. What I knew and what I have further learned is compassion is foundational to nursing practice. It's necessary. And in difficult times, it can be a burden. If nurses weren't compassionate, they couldn't do their job. But that very care may bleed over into moral distress. I've encountered that with almost everyone in this room. I'm reminded of several patients, some of whom are still hospitalized. One who I was involved in, and you know, ethics gets involved kind of at the margins. We don't see the easy ones. We don't see the ones that you guys deal with every day. You don't have to look at me and go, oh God, she's here. But for example, a patient who was hospitalized over 100 days, multi-system failure, multiple blood transfusions, severe decubiti, he was clearly suffering. There were family issues. You mentioned culture. There were cultural issues. And one of the physicians, frankly, added to the problem. We don't know that ever happens, right? The family, however, continued to be hopeful. They insisted he was going to recover, and they demanded aggressive treatment. One of my two least favorite statements is do everything. I still don't know what everything means because you have to frame it in terms of goals, right? So staff were unable to provide a different kind of hope. I think Karen will probably talk about different kinds of hope later. Do you hope for a peaceful death? Do you want freedom from pain? Do you want the decubiti to not be as painful? Or do you not want futile CPR? A hematologist covering for the weekend told the family that she could treat his symptoms. And you know how the family heard that. That heard that as, oh, here's somebody who's going to make them better. And later, when the nurse asked this physician about the patient's prognosis, the physician said, oh no, it's futile. But she refused to tell that to the family. She provided the nursing staff, the patient, and the family with false hope and false distress. So there are circumstances in which it's very difficult to maintain your compassion. I want to talk this morning about what it is, kind of foundational. Why is it necessary for nurses and other professionals? Compassion, with passion. Did you know that the word passion is related to the word patient, which means one who suffers? Compassion is sensitivity to the suffering of others. It commonly gives rise to an active desire to alleviate the other's suffering. Suffering including physical, spiritual, or emotional hurt. Yeah, you can, opioids work, but your patient may still be suffering. The dictionary tells us it's a response to the suffering of others that causes us to identify with them. And it's that process of identifying that I want to talk about a little bit, because it's got to be bounded, it's got to be limited. You can't, they aren't family. But in some degree, they're like family. It does require that we see others as us, not as them. The Dalai Lama said it's a necessity, not a luxury, a question of human survival. Compassion may have the ability to induce feelings of kindness and forgiveness, which frankly can give people the ability to stop situations that occasionally lead to violence. It has an emotional aspect, but it is also based on a sense of justice and sound judgment, in your case, clinical judgment. It requires that we see the trouble as serious, not self-inflicted. Eric Cassell is a marvelous internist ethicist back east who has written beautifully about suffering. If you're interested in, I have some of his articles if you ever want them. He defines suffering as the distress brought about by the actual or perceived impending threat to the integrity or continued existence of the whole person. He points out that we all suffer crises, threats, and challenges to our sense of life's meaning and our hope for happiness. The tragic bearing of suffering awakens us to its reality, its tragedy. But in that there is community. Our own suffering awakens capacity for compassion in others. And in this community, we can find meaning for ourselves as well as for our patients. It's part of your role as a professional. Ron Leifer, a psychiatrist, said the underlying mandate of medicine is moral. It's based on the universal desire to avoid pain, disability, and death. So, although the concept of compassion requires that we identify with another person, it should not extend to countertransference. That's an expression psychiatrists use when they're trying to talk about the fact that we get so immersed in our patients that we identify, we take on their needs, not just identify with them, we absorb them. And we can't tell the difference between what's going on with us and what's going on with them. It is bounded, it has limits, and boundaries require judgment with respect to safety, best interest, and self. I sometimes tell people, and I really believe that doing ethics is often about boundaries. How far can I go? How far should I go? I was giving a talk to the charge nurses, and I pointed out that patients' rights, and we were talking about patients' rights and responsibilities, and I pointed out that patients' rights to refuse certain treatments do not extend to their right to refuse basic, necessary, routine care that's required for their well-being. And one of your ICU charge nurses and I continue to have that conversation because patients do have the right to refuse treatment, but at what point does that right lose its authority? So if we've got a patient who is refusing to have his legs amputated, we cannot amputate those legs, the court tells us, unless his life is in imminent danger. And does everybody know the difference between law and ethics? The law tells you what you can do. Ethics tries to tell you what you should do. It doesn't march in and say, well, you should do this and you should do that. It's based on principles. It's based on all kinds of choices and other variables. So this patient does not have to have his legs amputated. On the other hand, nor does he have to take psychiatric drugs. But legal says he cannot refuse blood transfusions. He cannot refuse being turned. He cannot refuse having his dressings changed. Now, if you don't think that provides significant moral distress to the nurses, it does. And it turns the discussion of compassion into a very much more complex, I think, and rich discussion, and it's one that does require judgment and is an ongoing dialogue. The professional role also has boundaries, and in some ways, compassion can conflict with the professional role. The professional role calls for commitment to the patient in a very specific, limited context. It puts the patient's interest above its own. The physician doesn't order a treatment because it's going to send his kid to college. He or she orders it because it's necessary and appropriate and will provide some benefit. There's a sense of calling, of obligation based on a promise. These are the promises I make to you, and I'll act as your fiduciary. But it also requires distance. I don't want my doctor to even allude to our professional relationship outside the clinic, and better yet, please don't even say hello if I see you at the movies. And I prefer, try at all costs, not to see friends professionally. Why is that? Because those are our private lives, and the professional needs to be dispassionate. Why do we have rules at the hospital about not taking care of members of your intimate family, your immediate family? And remember how angry we are with professionals who step outside their role. The teachers, the clerics, doctors, and high school coaches. Professionalism requires that we keep confidence and respect privacy. Ordinarily, there's no conflict between professionalism and compassion. And patients are more or less appealing, compliant, satisfied, and your control over their recovery is limited, even in the best of circumstances, and your time with them may be limited, and it may be periodic. But patients may transcend suffering by finding meaning or relief, help from others, and that includes compassion. If I may quote Kahn in an article in the New England Journal, it's more important to know what kind of patient has the disease than what kind of disease the patient has. However, you also have a whole other life. There's the relationship, but there's also the you. And when things aren't going well in your own life, it becomes more difficult to be compassionate. When patients don't recover, they're non-compliant, or plain mean, there is very significant pressure on you. And their families are a story unto themselves. These difficult patients and families acting out their own fears and anxieties make it more difficult to feel and act compassionately. The professional community of friends, our colleagues, are usually allies, but that's not always the case. And we may encounter the indifferent, the downright difficult or disrespectful. And there's that word, respect. Some of us argue that ethics is based on respect, that if one can continue that. Today's meeting says no, there is more than respect that is necessary for a therapeutic relationship. And clearly compassion is one of the virtues that is paramount. It's critical. So, who gives and who receives respect? Unfortunately, physicians and other co-workers rarely, but sometimes, can add to the problem rather than enhance your goodwill. So can the ability to be with the other, be with the suffering, and the desire to alleviate this be taught? Can it be sustained? One wonderful article that I found in the nursing literature points out that the usual instructions about eye contact and leaning forward and touching the patient's elbow at just the right moment are only outward manifestations which can easily be faked. He says systematizing compassion risks inducing a parade of disingenuous gestures that will be read as artificial and patronizing. We all know when we're being patronized. Patients know when we're faking it. He argues it can't be taught, and compassion arises not from will, but from a deep sense of goodness. And as such, it's an art, and it has to be demonstrated for others to learn it. You have to demonstrate it for your staff, and your families, and your patients. Watts, who writes in the nursing literature, says, "We are not destroyed when patients suffer or die, but rather deepened and becoming better able to open ourselves to the complex lives of the distressed and infirm the next time around." There's a mysterious adjustment toward equanimity in which we can hold both worlds, that of safety and that of danger, simultaneously without calamity. This way of knowing is not primarily intellectual, it's emotional. One of the issues we've been talking about at Ethics Committee lately has been the role of emotion in ethics and in caretaking. There's some wonderful articles about the unappreciated role of emotion. I think everyone in this room, however, does appreciate it. There are risks to compassion, and Janice, do we have the handouts? I'm not going to look at them now. Good. There's a cost to sharing. Professionals who listen to clients' stories of fear and pain and suffering may feel similar pain because they care and worry about it. Physicians, social workers, and counselors have been identified as health professionals at risk for fatigue, but nurses are particularly vulnerable to compassion fatigue. You often enter the lives of others at very critical points and become partners rather than observers. Sabat noted, in its simplest form, compassion fatigue implies a state of psychic exhaustion. It's a severe malaise resulting from caring for patients experiencing various aspects of physical, emotional, and social pain. It's one of the costs of caring sometimes. It's characterized by a progressive state of emotional unease. And you go from compassion to discomfort to stress. And if we're not careful, and I think days like today are critical, it can evolve to fatigue and finally to burnout. These tables, and please, you don't need to look at them now, but they describe the different kinds of compassion fatigue, and it needs to be addressed in its earliest phase. Boyle is an oncology nurse who wrote about countering compassion fatigue. She said, "Nurses care for ill, wounded, traumatized, and vulnerable patients, and their charge thus exposes them to considerable pain, trauma, and suffering on a routine basis. Few nurses anticipate the emotional implications and sequel, either that comes from those close interpersonal relationships with patients or with families." I wonder whether young nurses are surprised by the amount of stress and fatigue that this kind of work imposes on you, and how the older nurses have learned to adjust to it and to work through it, to see the patient in the bed. For health professionals, it also arises when you have, when the emotional boundaries become blurred to the point where you unconsciously assimilate the distress that patient is feeling. And I know in the 2+ years I've been at St. John's that there have been patients both on Caritas and on oncology where that has become a real problem. You know, the ethics literature says there's no difference between a very old and a very young patient, and that death, the last breath of life is as critical as the first breath of life. And yet I think you feel greater moral distress when you have young patients, and we've had several on both units who have really made it very, very difficult emotionally for everyone involved. Over time, you may begin to feel self-blame, futility, or impotence, especially if these scenarios get repeated. Burnout has been described as the loss of the ability to nurture, and there are multiple environmental stressors such as expanding workload or long hours, perception of management indifference, which is not a problem here, continued or repeated complex cases, or those with bad outcomes, difficult patients or family, and I think you could add to this brief summary. It may also be an outcome, as I mentioned earlier, of transference. According to Figley, professionals who listen to clients' stories of fear and suffering may feel similar pain and suffering because they think they're losing their own sense of self to the patients they serve. So I want to, if I may, I'm going to skip over the tables. You've got them. I'm not here to read. I'm here to talk and listen, hopefully. I do have some reflections, and if I may presume, a moderate bit of advice. As clinicians, we need to more carefully work through what separates the appropriate management of hopes from their inappropriate manipulation. Because whether we want the responsibility or not, we constantly interact with our patients' hopes. Sometimes simply being silently present with a patient may be the most meaningful kind of care. I'm so happy to see some of you nodding. Eliciting the personal stories that accompany your patient's illness. Acknowledge the effectiveness of their stories of sickness on patients' broad life experience. Recognize their suffering. In my work, it's a little bit of detective work, it's a little bit of clinical work, it's an awful lot of narrative. It's an awful lot of the story. The ethics question that gets presented is rarely the ethical dilemma that I find as I dig deeper. You know, this patient doesn't want this, or is demanding that, or is denying this, or refusing that. And you find out what's going on and where the family sits in this, or where the family doesn't sit in this, and what the physician's views are. Last week, I think it was on the 4th floor, I was walking toward a patient's room, and on the way the physician said to me, "He's obtunded, he's vegetative." And I walked in, and this patient who never opened his eyes, never opened his mouth, was able to nod appropriately. And in speaking later with the social worker and the nurses, they said, "Oh no, he knows. He can answer appropriately, he's consistent, and his wants and diswants, is that a word, are pretty consistent." So, listen to their stories. I know time is an issue, and that's a burden everyone is feeling. It's one of the stressors I didn't mention, but I would. If you feel the need, discuss your concerns with your supervisor, and know that the ethics committee is available 24/7. I would like to stop for a minute and listen to you. What kinds of comments or questions or ethical issues do you see or want to talk about with respect to compassion?
Actually, you mentioned, brought something, been thinking about this patient that we have in oncology who has this fungating carcinoma coming out of her breast. And you just mentioned something about that she's refusing everything, treatment and everything. So she says she lives with this, the patient mentioned she lives with this monster. It's huge. It's, you know, if we all think about this, let's just cut it out and give her a quality of life that she deserves. But she's got some mental issues also. So what do you do in a case like that?
Let me give you the legal, the ethical, and then let's talk about the story. Legally, when a patient comes into your hospital, he or she has given permission, and I don't talk about autonomy and rights as much as permission, has given us permission for routine care and routine touching. And you have an obligation to do what's in their best interest. They also have a right to refuse those procedures that require informed consent, those procedures that, as we all know, have alternatives and risks. And first thing in this particular case, I'd want to make sure she has capacity. Now, capacity, because you mentioned there are some issues. Capacity in California by statute is the responsibility of the primary care physician. But many primary care physicians aren't comfortable. And so they can delegate either to psychiatry or another physician. Capacity may fluctuate. There are lots of myths about capacity. But I'd want to know if she has capacity. Does she really understand? Does she know what's going on, what her alternatives are, and what it is she's saying no to? And then, frankly, if she does, and if these choices are stable over time, and this represents her authentic self, if we have the luxury of having some family that can corroborate it, we may have to respect it. When I say that, it sounds like respect comes grudgingly. It's, you don't want this option. Respect doesn't come grudgingly, but we may have to comply. So I'd want to know, is she in-house now?
Yeah. So I was going to talk to you about that. Eventually tomorrow, because it's a long story. She's been seen by the psychiatrist also. I don't think she's capacitated to make that decision. She's schizophrenic. Yeah.
I won't mention her name publicly, but I got a call yesterday afternoon from the psychiatrist who said that he had requested an ethics consult 2 days earlier, and I was never called. I shouldn't mention that here, should I? So one of the things I want to talk to Janice about is who's supposed to call me? Because normally that doesn't happen. But if her last name begins with an A, yes, okay. That's on my list when I leave here. Yeah.
We'll see you tomorrow.
No, you'll see me. I have to give a talk on physician-assisted suicide at the Well-Being Committee at 12:30. If you want to talk about that, I'm really prepared. That was easier than this. Now, this topic, this thing that you're talking about today, is so incredibly important. I still teach at the graduate level, and in my work, I have gone from the textbooks that look at principles primarily to the textbooks that look at virtue. And compassion is one of the great virtues. And it is so critical to what you do. Thank you for that. Any other questions or comments? Yes, doctor.
I think that the situation of this particular patient, I believe, in my opinion, that it's our moral obligation to see that that individual is comfortable, and that individual, whether mentally able by our standards to make intelligent, what we call intelligent decisions or not, it's a decision that that individual has made regarding her own health. And I think that as caregivers, it's our responsibility to see that she's as comfortable as possible and that her wishes be granted. I don't think that we can impose, what she requires is an enormous surgical procedure, and I don't think that we can impose that on anyone.
I agree. I have not seen the patient. I don't know any of the facts. And the medical facts are critical. In doing ethics, that's the framework, obviously. But if this is a patient who truly lacks capacity to make decisions, depending on the risks, as I said, and the complexity of the procedure and the outcome, it's a conversation with her to some extent, but also with family. And who was she before? And if you point out something that I do need to mention, if someone lacks capacity to make a decision, we look to what they have told us in the past, if they have had capacity in the past, preferably through advance directives, if not through conversation with family and loved ones and their physician. And if we have none of those, then we go to best interests. And where I hear you going is a very significant tension between what's best for this woman under these circumstances. I don't know the severity of her psychiatric disability. The psychiatrist thought it was significant. So, and I don't know if she's in pain. So those are all parts of the beginning of the story. It's why I'm still passionate and compassionate about my work after all these years.
I have a question, or something that I'd like, I don't think there'll be an actual answer to it, but something for discussion, would be that when we have
I'm sorry.
patients who are having a very difficult time, and let's say the mother is being very protective of her child who is sick. Child would be maybe teenager, young adult age, and becomes abusive to our staff. That's when I become defensive, and I don't think as much about the patient and the mother's relationship as much as I then roll into being the person that needs to protect the staff from the mother. That, I'm thinking about young nurses particularly who are vulnerable emotionally, being in a room with a patient that's their age, with a mother telling that nurse that she's stupid. I can't believe you're a nurse. Do you know what you're doing? what are you doing to my daughter? So I have staff come to me with that kind of an issue, and it really affects me because I can't make much of an impact. I can't really change that. I can talk with the mother certainly and try to help the mother come around and look at it differently. But that doesn't usually work when someone's kind of stuck in that position. But
We're back to boundaries, aren't we?
yeah, and it's difficult for me to then feel like I'm supporting the staff. You know, in other words, I'm telling them, you got to put up with this and go back in the room and take care of this patient, because that's really what they have to do. But where's my compassion for my staff?
Well, you haven't lost your compassion. What you're lost, I think, you feel like you've lost your power. I think you feel like you're impotent to really be effective, and I'm not so sure you are. You know, one of the problems is that the mother isn't a patient that we can treat, and yet she clearly needs treatment, but I think social work should be able to help. You know, I'm willing to try, and you and I have had conversations with parents of patients who, that one in particular. I hate threats. But if they're disruptive, you have to call security. You know, tell them I don't want to go there, but I may have to call security. Yeah, yeah. And I have spoken with administration and gotten back up in these situations. It's a last resort. It's not us, them, and that was the point I was trying to make. It is we. But I do think we have to be real clear about our own boundaries and keep supporting your staff. I mean, what else can you do? And one of the things that I understand there's a history of that we're no longer doing is permitting families to dictate what nurses are assigned to treat which patients. How do you handle that?
I think that still does go on. And sometimes the nurse is the one that removes him or herself from the case because they need a break, or they're recognizing that they're having some personality conflicts with either the patient or the family member, and they're just not the best person in the room right then. Maybe they need to take a week off. Maybe they need to never go back in the room again.
Right.
But families do that, and that has become a problem when you've got a list of 10 people on the board that she doesn't want in the room.
Yeah. And as a charge nurse, dealing with that situation, because you want to provide the care for the family and the patient, and you know that there will be conflict between nurse and, you know, family and patient, you don't want to put that nurse in that position. And you get the nurses that are willing to take care of them, but then that's where compassion fatigue comes in, because they're the same ones taking care of them over and over, and you want to give them a break. Yet you have family members saying, I really don't want this person, you know, because you know it'd be worse for the whole day, for both nurse and, you know, and so you feel that difficulty. You have to make that decision as who's going to care for them.
Yeah, it is. It's a judgment call, and I'm not going to give you a non-answer there. It's very difficult.
Yeah.
You want to?
I was just going to share, I think, you know, especially now with us, we don't just look at the patient, we look at the family. And in doing so, what I found in being a family member that didn't have coping skills in place when I was taking care of a family member that was dying, I did not have the coping skill of dealing with a patient dying that was my little sister. My point being is no one came and helped me. And I think that I can relate to these family members that don't have these coping skills in place. And we really should think about, like you said, someone could call you, or we should have somebody that could intervene because that's a mother that's saying,
yes,
my kid is dying and this nurse doesn't know what they're doing, even though they do. So I feel really passionate about that. I think that, you know, it's not the mother's fault.
Of course not.
And so why don't we get something in place for something like that?
Absolutely.
You know, that's not busy necessarily, that can get into the emotional part and not the nursing part.
Yeah. It doesn't come up all that often, but when it does, it can traumatize a whole unit. Janice has called me on more than one occasion, and with more than one family. Marcel?
this brings up some of my past experiences that, there's, and you all experience on a daily basis, there's always situations where you might have two situations where the parents or the mother or the father handle it differently than another. And I've seen some that they go through that where they have the experience of losing a son, daughter, or whatever. But they want to be part, they want to give back in some way because it's maybe part of the grieving process or it's part of their healing process where they're willing to help out. That if another parent or mother has the same experience, they come back as a volunteer and they say, how can I help work through that? Now, they're not trained professionals, but they have that empathy and that experience that they've been there.
It's great.
And I don't know, that might be something we think about, is there
Love
could be
it.
some people in our community that would be willing to do this.
Love it.
It seems like the culture with the patient or in caring for patients, my heart's desire is to have compassion carry through even stronger than, but so many times we have to set, around safety, set limitations for the patient because they don't know any better. Outside of education, how can we infuse that with more compassion to help them arrive where these safety needs are immediate, like fall risk, and or now with like pain management, we have patients that are almost so sedative, yet they're, still expressing pain.
I think if you can continue to feel compassion and continue to behave in that way, it gets communicated to the patient. If you're doing, you're lifting those bed rails and you're annoyed but if you're still seeing that patient in the bed and you're still talking kindly and still feeling it, there's got to be a song about still feeling it, isn't there? They'll get it. Yeah, I don't think you can teach it. But as far as culture is concerned, I wanted to mention, because somebody raised it, I don't think we can generalize. I think you have to know where that patient is situated. And that's part of getting the story. Thank you very, very much. Well, thank you.